Thank
Okay.
you.
Thank you for coming, everybody. Today's topic is HIV-infected patients with CNS lesion. Evaluation and management of HIV-infected patients with CNS lesion can be challenging. The main differential diagnosis for the CNS lesion in this population mainly depends on the degree of immunosuppression of the host, whether the patient knows his or her HIV status, or whether the patient is on background prophylaxis for PCP, which will cover Toxoplasmosis prophylaxis too. So if their CD4 count is more than 500, it's more or less same as non-HIV population. It can be benign or malignant brain tumors or metastases or brain abscesses. If their CD4 count is between 200 to 500 microliter, then it can be due to HIV-associated cognitive and motor disorder. But usually they do not present with focal lesions. If their CD4 count is less than 200, then it could be due to opportunistic infection such as toxoplasmosis, cryptococcus infection, or HIV-associated tumors such as primary central nervous system lymphoma. So CNS lesion can be divided into two categories. One is CNS lesions with mass effect, and second one is CNS lesion without mass effect. So CNS mass lesions are characterized by the presence of swelling, edema, and mass effect on the surrounding structure. So sometimes, especially lesions located in the posterior fossa, can have a cerebral herniation. The CNS lesion with mass effect can be divided into toxoplasmosis, primary CNS lymphoma, brain abscesses, including cryptocarcinoma, and tuberculoma. In developing countries, tuberculoma is probably the most leading cause of CNS lesions with mass effect. The second category is a CNS lesion without mass effect. Differential diagnoses include PML, which is progressive multifocal leukoencephalopathy, HIV encephalopathy, or cytomegalovirus encephalitis. So when we do the imaging study, we prefer MRI over a CAT scan because MRI is more sensitive in determining whether the lesion is truly solitary. MRI has greater sensitivity for the white matter disease or lesions in the posterior fossa. So we prefer to do MRI than the CAT scan. I'm going to go over some of the MRI finding of the lesions, and then I'll go into each individual disease. The first one is toxoplasmosis. As you can see, there are two patients with the CNS lesion. The first patient on your left side is in the imaging study with the CAT scan, because you can see the bone window by the CAT scan. This is a CAT scan of the head with IV contrast. You can see hypodense lesion with the ring enhancing lesion with the surrounding edema. So this is a typical for toxoplasmosis. I would say about 90% of brain lesions with the toxoplasmosis are ring enhancing lesion. And the second patient has two MRI. The first MRI is T2 MRI without contrast. And you can see is a hyper-intense ring-enhancing lesion. But on T1 MRI with contrast, you can see hypo-intense ring-enhancing lesion. There are some typical sites for the toxoplasmosis. Most common sites of infection for toxoplasmosis are corticomedullary junction, as you can see right here in red color. Second one is basal ganglia with turquoise color. And the third one is the thalamus, as you can see right here. So these are the three common sites of toxoplasmosis infection. For the primary CNS lymphoma, the most common site is located in the periventricular or peri-infantimal white matter, as you can see in the yellow color.
I do not at the moment.
Can you see it?
Right now, no.
And another one is corpus callosum. It's in tortoise color, as you can see right here. Corpus callosum and corpus callosum right here. Primary CNS lymphoma with the T2 imaging study. As you can see, mass is iso-intense to hyper-intense to the gray matter with the internal foci of cystic degeneration or necrosis in the center. But with the flash sequence, you can see hyper-intense lesion in the spleen of the corpus callosum. As we discussed earlier, corpus callosum is one of the common area for primary CNS lymphoma. Next topic is PML, which is a progressive multifocal leukoencephalopathy. On the CAT scan, you can see hypointense lesion on the right frontal area. But on the MRI, you can see a hyperintense area on the white matter. So PML affects white matter only. Gray matter is spared, as you can see in this radiology pathology correlation. As you can see on the autopsy, gray matter was not involved. Only the white matter is involved, which can be seen on the MRI. The next one is MRI of the brain lesion in a patient with HIV-associated dementia. As you can see, the white matter of the bilateral area is involved in the both frontal lobe associated with the subcortical atrophy, as you can see in HIV-associated dementia. So once patient comes in with CNS symptoms, we may or may not know their CD4 count viral load. But after the CAT scan or MRI, we can see whether patient has a mass lesion or without mass lesion. So I like this category from up to date. If there is a mass effect on the MRI, then you can follow the algorithm on the left side. And if there is no mass lesion, then you can follow the algorithm on the right side. So they may have impending herniation with the mass effect. So in that case, patient needs steroids and an open biopsy and decompression by neurosurgery. And if they do that, we may have tissue biopsy and culture, and we may know the diagnosis. And depends on the diagnosis, we can start treatment. If patient doesn't have impending herniation, then we can check for toxoserology. If toxoserology is positive, or if we can do a lumbar puncture, then we can have a CSF study to be done. And depends on the CSF study, we can do a treatment, a specific treatment. If CSF cannot be sent, or if we cannot do a lumbar puncture, then we can start empiric toxoplasmosis trial with sulfadiazine and pyrimidamine, and wait for the clinical response and radiology response for 2 weeks. So if there is response to the toxo treatment trial, then we can continue treatment, and there will be MRI 2 or 4 weeks later. If there is no response, then we have to do a biopsy and decide whether this lesion is truly toxo or something else. Let's go to the column on the right side. If the lesion is without mass effect, and see whether the patient is safe to do a lumbar puncture. If it is safe, we'll do a lumbar puncture and send for a specific diagnosis. If it is not safe, then we have to do a biopsy. So you can notice on this column that we don't do a toxoplasmosis treatment trial because toxo usually comes in with the mass effect. If it is without mass effect, and if we cannot do a lumbar puncture, then we have to do a biopsy to find out what the lesion is. And then depends on the lesion, we can start the treatment. The common laboratories that we sent for patients with CNS lesion include CD4 count, HIV viral load, serum toxoplasma IgM, IgG, even though IgM is likely to be negative because usually caused by reactivation or infection. And we can send a cryptococcal antigen, one different gold TB, because some cases tuberculoma can present with the mass lesion. If we can check CSF study, we can send for cell count protein glucose and PCR testing for Toxoplasma gondii, cytology, culture, CSF, cryptococcal antigen, and PCR for Mycobacterium tuberculosis. And we can send PCR for Epstein-Barr virus and JC virus. And we can do a chest X-ray as a baseline. And one thing to point out that CSF PCR for Toxoplasma gondii is 96% specific and 50% sensitive. So it may be negative in infected patients. So I'm going to go over each disease and talk about epidemiology and diagnosis. I will not go into treatment in detail because of the sake of time. So toxoplasmosis epidemiology is caused by Toxoplasma gondii protozoa, and disease is almost always caused by reactivation of the latent tissue cyst. So usually it's not recent infection, it is just reactivation because of the poor immune system. The seroprevalence varies widely in the whole world, 11% in the US, 50 to 80% in the European, Latin America, and African countries. The primary infection acquired from tissue cyst, the endoscopic meat, or raw shellfish, or ingestion of the sporulated oocyst in the swine, water, or food. There's no documented transmission from person to person, and the incidence and mortality rates lower in the US and Europe because of the widespread use of bacterial prophylaxis and because of the potent ART. Toxoplasmosis can present with headache, confusion, fever. I'd like to point out that fever is probably the most differentiating factor for toxoplasmosis compared with the other etiology of CNS lesion. And they can also present with lethargy, seizure, poor coordination, focal weakness. Signs include focal sign, temperature more than 38.4 degrees Celsius, it should be Celsius, and abnormal level of consciousness, hemiparesis, ataxia, cranial palsy. So diagnosis is mainly by serology because it's positive in almost all patients with toxoplasma infection. Negative IgG makes diagnostic unlikely, but it is not impossible. So somewhat we can exclude toxo by negative IgG, but it's not always negative. IgM is usually negative because it's not a recent infection, it's a reactivation. So the definitive diagnosis is by compatible clinical syndrome plus mass lesion on imaging plus detection of organism in the clinical specimen, in the case, brain biopsy. So if you want to confirm the diagnosis, we need a brain biopsy and detection of the organism in the pathology. Let's switch gear and talk about primary cerebral lymphoma, because it is usually a huge lesion, mostly single lesion, but it can be multiple. Compared with the toxo is multiple lesions. Primary cerebral lymphoma is a single lesion. Because the lesion can be huge, up to like 4 centimeter, 5 centimeter. The patient can present with focal neurological deficits about 70% of the time. They can present with neuropsychiatric symptoms, signs of increased ICP, seizure, or ocular symptoms. Primary CNS lymphoma diagnosis is by CSF analysis. Sometimes you can see presence of malignant lymphoid cell in the spinal fluid up to 40% of the patient. If CSF study is negative, then we have to do a biopsy of the brain and see whether we can see malignant cells on the pathology. Let's switch gear and talk about brain abscesses, usually caused by oral pathogens, caused by strep more than staph. In immunocompromised patient, atypical infection, fungal infection is also common, such as aspergillus. It can be caused by nocardia, rhodococcus, listeria, and unusual granulomatous inflammation such as cryptococcoma, syphilitic gummus. In the developing world, neurocystic sarcoidosis and tuberculosis can present as single or multiple mass lesion. Probably tuberculosis is the most common mass lesion in the HIV patient in the developing world. Next topic is the PML, progressive multifocal leukoencephalopathy. It is an opportunistic infection caused by polyomavirus called GSE virus. It is characterized by focal demyelination of the central nervous system. The virus distribution is worldwide. Seroprevalence rate ranges from 39% to 69% in adult. Most of us already have infection during the childhood, but it's not recognized, usually just virus infection and likely asymptomatic chronic carrier state. But once immune system is suppressed, it can reactivate and then cause this progressive multifocal leukoencephalopathy, and it has very high mortality rate. It usually occurs with the patient of low CD4 count. I've seen patients with single-digit or double-digit CD4 count, but it may occur in CD4 count more than 200. Even though they are on ART, they can still have it. It can be caused by iris immune inflammatory response syndrome. The clinical feature of PML in the descending order include stroke-like symptoms. So patient can have weakness, cognitive impairment, speech abnormalities, headache, gait problem, visual problem. The signs include hemiparesis, gait disturbances, cognitive impairment. So essentially like stroke-like symptoms. The diagnosis is by CSF evaluation, looking for the JC virus PCR. Usually positive in 70 to 80% of the patient population who are not on antiretroviral therapy. If they are on antiretroviral therapy, then PCR can be negative. So in those cases, if PCR is negative for JC virus, we recommend doing brain biopsy to look for the oligodendrocytes with intranuclear inclusion. And they have pathognomonic features by pathology by looking at this bizarre astrocytes, lipid-laden macrophages, and this inclusions in the oligodendrocytes. Serology testing is not useful because some of us already have the infection and antibody is always positive. But newer approaches are under investigation. Next topic, next slide. So outcome of PML, before we have this antiretroviral therapy, mean survival weeks is only 18 weeks. 10% recover spontaneously. But after the ART, their survival is longer. The mean survival is more than 1 year, but 50% die in the first 6 months after the diagnosis. Patient can be left with moderate to severe disability. The cytomegalovirus disease, as you know, it is a herpes virus family, double-stranded DNA virus. It can be disseminated or localized disease. Occurs in patients with advanced immunosuppression with CD4 count less than 50 cells per microliter. Risk factors include starting on ART, previous opportunistic infections, high level CMV viremia, or patient with a very high HIV viral load. Same with other infectious etiology, usually is caused by reactivation of the latent infection. The cytomegalovirus disease clinical manifestations include dementia, lethargy, confusion, fever, so it can mimic HIV dementia. When we do a CSF study, we can see lymphocyte pleocytosis, low to normal glucose, normal to elevated protein. It can also present with ventriculoencephalitis, usually acute symptoms with cranial nerve palsies, nystagmus, and other focal neurological signs, and rapid progression to death. On the CT or MRI, you can see periventricular enhancement. We can diagnose CMV by doing blood testing. We can do a PCR testing from the blood, antigen assays. But usually it's not good diagnosis for CMV and organ disease because viremia usually present in end organ disease, but it may be present in the absence of the end organ disease. So by seeing viremia, we cannot say that the organ is involved. So sometimes we have to do a tissue biopsy to look for the CMV inclusions. Same is true with the CMV colitis. We cannot, say a CMV by looking at the CMV in the blood on the stool. We have to have a tissue biopsy from the colon to look for CMV colitis. Antibody level is not useful because most of us already have antibody because we're exposed when we're a childhood. The diagnosis is by clinical syndrome plus CMV in the CSF or brain tissue or detection enhanced by the PCR testing. The last topic that I wanted to go through is HIV encephalopathy. Usually they present with subcortical dementia. meaning slow in memory, slow psychomotor, speech. It should be speech impairment, depression, movement disorders, and in contrast to the PML, usually HIV encephalopathy involve bilateral subcortical white matter, and usually they are non-enhancing lesion on the MRI. I think this is my, okay, one more slide. So let's see. HIV encephalopathy, I think encephalopathy is my last slide. So we can open up the discussion.